Thank you very much. It's great to be invited here to give this chair. Got a fantastic panel. So we've got some objectives here in this session. I'm delighted to be here. Two patients. I'm going to show you which one of these patients would you use imaging in and which one would you just go for angiographic guidance. This is a kind of weird start because that's not how my slides started. So let's play it from the beginning. So if we press play and we'll go back. We'll start the session. So I'm going to thank the EBC committee. I'm going to thank Boston for the invitation. I've got a great panel. Varney, Maciej and Johan are going to give us some brilliant talks. It's going to be a quick 30 minutes, hopefully, be on time. And what we're going to try and cover is the understanding of where imaging fits into our everyday practice, because we've just heard that you don't do it all the time. What are the potential benefits it brings to our practice? Update on some of the evidence, because there's been lots of evidence in the recent year. What are these barriers to why we don't use it? Is it time? Is it cost? Is it skill set? But what can we actually bring to the table? What does imaging bring and how does it help? So in the next slide, you're going to see these two patients that I've treated. Hands up in the room, who would use imaging for patient one? Quite a few. Who would use imaging for patient two? Who's going to be honest and say they wouldn't use imaging at all? No one. Okay, but there is difference between the two. So I'm going to, without further ado, I'm going to hand over to Maciej. He's going to give us a talk, and it's going to be a great talk because I've seen the slides.
Thank you, Peter. So let me show you a very practical case, just showing how imaging, particularly IVUS here, works and what kind of benefits can we have doing a procedure with IVUS imaging. Okay, so this is a 65-year-old woman with stable coronary artery disease, quite severe angina, class 3, and what you can see here is the left main stenosis and also circumflex ostial lesion and long lesion in the LAD. Perhaps LAD does not look very severe, but you will see in IVUS that there was significant stenosis as well. So this is Medina 111 left main lesion, and in recent times we used to do all left main cases with imaging, and our approach, our regular workflow is just we are setting the length of the lesion, we look at the plaque composition, and of course we measure the diameter of the vessel. So here are the data. The proximal LAD reference diameter, as usual, is 3.5. Not much calcium, just focal calcifications. Then we have appreciate the minimal luminal area of 3.3. Then we have left main with also a very significant tight stenosis, 3.55 minimal luminal area. Not much calcium, and ostium of the circ is on the third image at the 12 o'clock. So the case was done by my colleague, and he decided to do the complex technique. But before he checked the length, of course, of the lesions, and you see he decided to cover LAD and left main up to the ostium, so it's 28 millimeters, and reference vessel diameters we already heard, taken from IVUS. So he started with decay crush technique. So after pre-dilatation, of course, we didn't use any ablation technique because there was no much calcium there. You see the positioning of a circumflex stent with protrusion into the left main. Then crush with properly sized balloon, which is 4.5 here, and first kissing with 2 short NC balloons. Then, of course, main vessel stent, 3.5 over 33, and again, second POT, second kissing, and just appreciate the final angiographic results. So they were very satisfied of this result. I think most of us would leave it like that, if not for the imaging. So they used imaging, fortunately, and of course, if we use IVUS to check the final result, of course, we concentrate on the stent edges. We look for some dissections or some deformation. Then, of course, a position of the stent is very important. And finally, stent expansion, which should be an optimal results, 90% of the reference luminal area. So this is the image. As for on the right-hand side, you see the edges of those two stents put in the circ and the LAD, and there is nothing wrong there. There's everything okay. Large lumen, no dissection. But during the procedure, they noticed something strange in the left main. So just appreciate this, and then they call me. And of course, most of you perhaps know that if you see more than one layer of the struts of the stent, if you deployed only one stent, that means that you have a stent deformation. And this is, of course, an ostium, but not only the ostium of the left main. So the guiding catheter, which was 7 French from the radial approach, just crushed partially the stent at the ostium, which was completely not visible on angiography. And we know that this complication is not a benign because in Excel study, those patients who were found by core lab having stent deformation, the MACE rate was almost tripled across 3 years, and actually the stent deformation was one of the independent predictors of MACE. So of course, this was quickly corrected with pre-dilatation, but it's still deformation was present, and a short 4.5 12 millimeter drug-eluting stent at the ostium was implanted with POT and good final result. And now you clearly see that the stent is nicely opened with a little protrusion into the aorta, which is nothing wrong, and the procedure was completed. So I think that this case is a very clear and nice presentation how IVUS may work and how IVUS may save lives in our patients. So this is a great data from the huge registry of England and Wales. And you see that after propensity match comparing of left main stenting with and without IVUS, you clearly see that there is a separation of the curves with a significant reduction in mortality after 1 year. But what struck me mostly in this study is that the effect of IVUS was observed very early. So you see, even in hospital, significant reduction in mortality of patients. So I think my case was one of the explanation how and why IVUS might work so quickly in this kind of patients. You'll hear more data on IVUS, more new data on, later in the session, but this is just another meta-analysis showing that IVUS reduces mortality in left main stenting in our patients. So just to summarize, the IVUS is a very useful tool in the diagnosis of severity and distribution of left main disease, and of course optimization of the stent implantation. It plays a vital role in the recognition and management of complications during the procedure, and as compared to angio-guided left main stenting, IVUS, we are all sure, I think, improves early results and patient long-term clinical outcomes as well. Thank you very much.
So that's a fantastic presentation. Vine, I'm going to come to you first. What's your main learning from that case?
That you can't correct what you can't see. You know, so we talk about, imaging, we talk about angiographic result, and I think there is a transition where previously we would have been happy looking at an angiogram and saying that looks like an excellent angiographic result. Certainly when I was a trainee coming through in the early years as a house officer or an intern, as you want to call it, you'd read the notes from the cath lab and it would say an excellent angiographic result. But I don't think an excellent angiographic result really correlates to a true excellent result, as we can see, particularly in certain lesion subsets.
Very good. Johan, how do you feel when you see left main done in your institution without imaging?
Well, yes, scared, I guess. I guess we're trying to increase the number of left mains of imaging, and we're about 80% now, but I think sometimes we take the quick route and we don't do it, and then of course we miss things like this.
Maciej, do you think you would have spotted it on the angiogram alone?
No. After so many years of practice and a long-term use of imaging, I think that we cannot get rid of this tool during our procedures. So definitely we recommend strongly to any complex bifurcation procedure using imaging, mostly IVUS, and left main is a typical indication to use IVUS because you can observe not only the bifurcation but also ostium of the stent, which was very important in this case. We noticed something wrong, and even we know very well that it may happen, and we pay attention, try to avoid, but still it happens.
Has anyone got questions? Yeah.
Okay. Do you think that the deformation was induced by the guiding catheter? The first question. And the second one is why implant a second stent? Or no? For this type of deformation, a re-expansion with balloon may be a good alternative, avoiding a new layer of metal in a decay crash.
Yeah. I'm absolutely sure that was created by the guides. As for using the second stent, we try to we first post-dilate again with 3.5 balloon, and the angio image was much better. But still, there was a kind of ugly image of the ostium of the left main because it was not covered, so the stent was shortened. Yeah? Of course, we can argue whether it should be done or not. Perhaps we could also patients could be left on the safe side with just one stent. But we decided to do this, and you saw that image was quite good, and the area was okay. So I think. It's possible to do like that. Jacek has some comments.
In such situation, I believe that first we need to take into account tapered nature of the left main, which is very often, and second that that compliant balloons are better than non-compliant, because usually, and I agree with you that usually there is no problem to treat these deformations without any additional stent implantation, just with the balloon, appropriately sized balloon.
Do you think like we have the MLD max algorithm for the OCT? Of course, that works for IVUS as well. So we can make it MLD maxed, MAXD, and add another D for deformation in the end. So that whenever we are checking the final IVUS, we check for medial apposition, medial dissection, apposition, expansion, D maxed, D for deformation. So it always, you will always check it. I always use it like that, MLD maxed.
Very nice. Very nice.
Yeah, very nice. It's always nice to have, a very nice algorithm or names. Yeah, but definitely what we need, we cannot forget about looking at the edges of the stent. Distal, and other than left main procedures, distal of the stability of the stent is even more important, because if there is something wrong there, then the risk of thrombosis and dissection is much higher.
So I think, Eddie, if there's no other questions, we'll move on. So I think you've shown beautifully how systematic imaging pre, peri, and post gets you to a better place potentially without using it. Now, Johan's going to talk about the evidence behind where imaging sits.
Good evening. Thank you for the invitation to present very briefly a clinical update on evidence for intravascular imaging. We could talk about this for hours, but we only have 2.5-3 minutes. So I'm sure you're all aware of this landmark study published earlier this year, Renovate Complex PCI. In this study, 1,620 patients were randomized to either imaging-guided PCI, OCT, or IVUS versus angio-guided PCI, complex lesions, CTOs, bifurcations, etc. And I'll just draw your attention to the left main, which we're talking about this evening. 11.7% of these patients had an unprotected left main PCI performed. We're all aware, I'm sure, of the results. On the left here, you can see a significant reduction in TLF in the patients who had imaging-guided PCI. And when we look at kind of pre-specified subgroup analysis, the patients with the left main had really the most benefit from the imaging-guided PCI, which is pretty clear in this slide. Professor Stone discussed this at the ESC meeting in Amsterdam. This is one of his slides. Network meta-analysis of 20 randomized studies, more than 12,000 patients who are randomized to imaging-guided versus non-imaging-guided PCI. We don't have time to delve into all the information here, but studies were looking at OCT versus angio, IVUS versus angio, OCT and IVUS versus angio as in Renovate, and some other studies as well. And there were quite a lot of results. Just one to really focus our attention. The TLF rate was significantly reduced in patients who had imaging-guided PCI, as you can see in this slide here. And I've borrowed his conclusion slide, which shares that really compared with angiographic-guided PCI, imaging-guided PCI reduces the TLF by 31%, and also cardiac death, target vessel MI, and TLR by 46, 20, and 29% of cases, respectively. Stent thrombosis and also all-cause mortality are significantly reduced by using imaging. So I guess, as Dr. Stone also mentioned here, by using imaging in lesions, we can improve the patient event-free survival and enhance the long-term outcome of the patients. Especially for IVUS, as we've seen a moment ago in some data presented, also lots of other studies, it also permanently, well, it really reduces substantially the TLF rates in complex lesions, and I really think there is a strong case for elevation to class 1A, especially in left main PCI. Of course, what remains unclear is when should we use it, what specific lesions, apart from left main, which I think there really is sufficient data for, what are the optimal techniques, what do we use to optimize the results, and of course, looking at individual cases, countries, what are the issues, are the problems to introduce imaging? Is it legislative issues, is it training, or is it really healthcare and reimbursement issues? Of course, we also wait for the results of IVUS CHIP, which has been completed earlier this year, and hopefully we'll have a result of this, 2,000 patients randomized to IVUS-guided or angio-guided PCI in complex lesions. Thank you very much.
Thanks, Johan. That was very, very good to time. Finally, why don't you give us the barriers now, and then we'll have a discussion.
Great. Thanks very much, Peter. Thank you very much to EBC and Boston Scientific for the session. So these are my conflicts. So I'm just going to go through the UK intracoronary imaging survey data, a very sort of quick snapshot of it. We ran the survey in May 2022 with the objectives of reviewing variations in adoption of intracoronary imaging, understanding the way we distributed training, and identifying core barriers. So we got approximately 318 responses, of which actually captured about 30% of all practicing UK interventional consultant cardiologists. And a couple of key results. I can't move my slide forward. There we go. If we looked at what respondents thought by lesion in terms of the indication for intracoronary imaging, it's what you'd expect. So left main PCI, stent failure, optimization of stent result, ambiguous anatomy or to detect plaque rupture, and calcified lesions were identified as the core lesions in which imaging would be indicated. Bifurcations were lower at around the mid to late 50s in terms of the percentage of respondents. And this was what respondents actually thought the indication for imaging was. But if we actually looked at reality, so the blue line is perceived indications, as I've already discussed. The red graph is reported use in real-world practice. There was a discrepancy. For calcium, there was a 90% perceived versus a 58% use in real world. For bifurcations, it was 58% and 44%. In left main, it was 98% and 84%. And of course, we know from the left main national data in the UK that we only use IVUS or imaging in 70% of all of our left mains. So 30% of left mains don't get imaged. I think that's selection bias into the survey, and that the people that were responding were more high volume imaging operators. And then we looked at the barriers. And the first was procedural time and lab turnover. So respondents ranked their barriers to use of intracoronary imaging. Of course, this we can all understand. And that is that we just need to practice. When you start using a new tool, you're going to be slow. But if you train the cath lab, and as we become higher volume operators, we're going to get quicker. This is the Sigma learning curve, and you have to start the learning journey. The second barrier was training, proctorship, confidence, and competence. So the green line is operators that were trained, the blue line is operators that weren't. And as you can see, if you had formal training during your fellowship or as a consultant, you felt more confident in interpreting different etiologies on imaging. Again, if we look just at confident operators, even within the confident group, there were individuals that didn't feel confident interpreting calcium. Longitudinal stent deformation, as we've seen today, is important. Less than 50% felt confident seeing that on IVUS and being able to call it out. The third barrier was lack of data and guidelines. Well, we've already discussed that in our previous talks. And the fourth was cost effectiveness, which has already been demonstrated in a number of studies. And if you go into more detail on these, IVUS is actually cost neutral in some of these studies at 12 months and cost beneficial at 5 to 10 years on economic modeling. So I'm going to leave you with a final thought. This was a wonderful paper published by Gary Mintz about 6 years ago, Intravascular Imaging, Stent Implantation and the Elephant in the Room. And these are some of the barriers that Gary Mintz identified and some of the things that would lead into a good discussion. Thank you very much.
That was a fantastic run through and a very important survey. Well done. I'm going to ask all three of you to explain in your region and your centres what the barriers are.
Yeah, not later than 2 days ago, I organized a kind of workshop which is repeated every month. It's on a complex coronary intervention. And the last 2 or 3 times I asked the audience, what's the main reason of not using imaging IVUS? And I can tell you that every time I'm not too confident with the interpretation of the image I see. And so that was not the time, that was more the lack of confidence. They just see something, but they are not sure whether they know what they are, see, and how to translate it into action. Yeah? So I think they all need more training, more consultations, or I don't know. So it's
training for you.
It's a training for me.
Yeah.
Well, yeah, so I work in Belgium. I think there's numerous issues. The 2 main ones for me are, first of all, the reimbursement. I guess to use an IVUS Boston probe is 800 euros. It's not reimbursed at present, so the hospital carries that financial burden. Second, though, of course, I think Boston and Philips are working together to try and submit something to the government to get more money for that. I also think therapeutic inertia, but people think, oh, I've been doing this for years. I'm doing a good job. I don't need imaging. And I didn't show the data earlier during the study, the presentation there, but there's lots of data from Korea where it says that even if you're very experienced, IVUS on top of that improves outcomes. So I think those 2 things can be related, but reimbursement and inertia are the 2 main issues in my cath lab or in my country.
Fantastic. And Varney, what about UK?
Well, I think from what we've shown in our survey, there's 4 main ones, isn't there? But I think if you go into the data in more detail, which we haven't obviously written this paper and published it yet, but it will come out in due course. I think training and education is a big thing. And I think a collaborative and supportive environment for consultants and fellows alike to train without judgment and without feeling like they're being looked down upon for not knowing things, because lots of people come through training programs without high volume of imaging. So we've got to be collaborative and supportive, I think.
That's a very good answer. And now, anyone in the audience with an opinion on why it's question? Opinion.
You have a microphone too.
I'll reflect on the US opinion and tangentially from the guidelines committees. It is reimbursed, imaging is reimbursed in the US, but I think there's inertia on senior consultants and particularly smaller non-surgical PCI centers in doing it because the hospital brings the cost issue up of the console, or unless there's new equipment of the boom where things are integrated, people don't like the mobile cart coming up and connecting and all that. So that's a big issue. Personally, there is a drive for a class 1 recommendation setting. I think besides unprotected left main, it probably should be used for sizing and acute MI because it's so undersized. But I think if people just learn 3 things: sizing, stent failure, and knowing calcified nodules, I think that'll be more than enough. But I think there's a great push to try to push it up to class 1 recommendation. but there's a lot of barriers still, and I think it depends on the proportion of people who are interventionalists and non-interventionalists on any committee trying to drive that decision.
Oh, that's a good answer. Anyone else in the audience? Okay, I'll go back to the panel then. Left main, obviously you've shown a great case, and we've seen in the survey and in our real practice, 30% of people are not doing it. Are there any other subsets of cases where if you're going to use imaging, you think is essential? So, Johan, we'll start with you.
Well, I showed the case there of Renovate PCI where it was left main. It was really a good point, but I think also CTO PCI. I'm sure there's some CTO operators here as well, and I think we're using IVUS imaging in about 80% of CTOs, and I think that's another region where it can really improve outcomes, and data has shown that as well. So I think these really complex lesions, calcified lesions, are where we can really, in my opinion, make the biggest difference.
Yeah, to me, the more complex the procedure, the higher the indication to use the imaging. And another issue is any complications. So if you have stent thrombosis, for example, do imaging, because there must be a couple of reasons. If you have issues, problems during the procedure, we just could seen this today, accidentally crashed stents out of the lumen rewiring, abdominal rewiring. So you will never see it, especially in the left main, you will never see it without imaging. Yeah? So the more complex the procedure, and if you encounter any complication during the case, then use imaging.
Yeah, I very much agree with the rest of the panel. So, left main, CTOs, calcium, long lesions, ACSs are where they're seen to be more beneficial or most beneficial and have the best kind of value for money, as it were, given that reimbursement has come up. I think also, patient subsets, so renal failure, stent failure, that comes under your lesion, but also diabetics, as we've mentioned. And I think the other important thing to remember is in certain subsets of patients, you do get a health economic benefit with use of the imaging catheter. So for those who are struggling in smaller units where, your administration is saying we're not going to reimburse this because it's an expensive device. Well, actually in, patients that are diabetic, if you prevent a stent failure, so insulin-dependent diabetics, renal failure patients, etc., and in a patient that's already got a stent failure where they're much more higher risk of recurrent TLFs, the imaging device will be cost effective. So instead of blanketing it as a use for all, I think actually if those who are in countries where reimbursement is challenging can actually sell it to their administrators as high-risk patient and high-risk lesion subsets, you might find that they're a bit more amenable.
I think renal failure is a very good indication. We have now more and more ultra-low contrast use in almost only IVUS, just one injection in the beginning, at the end of the procedure. So you can really save contrast in this patient. So this is a great indication too. Yeah.
Agree. Johan?
There's a question over there.
There's a question. Yep.
Vani, you referred to ACS as being in the complex subset. So 80% of what we do, or 70-80% of what we do, is ACS. My limiting factor in my lab is time, not money. No one seems to know who pays for what in the NHS, but time is a limiting factor when there are always another 5 ACSs waiting outside. So do you truly believe all ACSs we should image?
No, that's a great question. Just to clarify, so ACS, if you look at health economic data, the ACS population is one that tends to get a better incremental benefit from a cost perspective. So that was more for people in countries where they're trying to fight for reimbursement and show the value of the device itself. I think in ACS, for me, if I take my personal experience, in ACS patients that have high patient risk features or high lesion subset features like calcium or left main bifurcations or, long segments of disease that are 50, 60 millimeters, then I would take imaging.
Good answer. I think we'll take one more question. Yes.
We should not forget about this data presented by Greg Stone and the reduction of stent thrombosis with stent optimization with intravascular imaging guidance. So the most important population of patients for this is high bleeding risk population, which was discussed just at the end of the previous session. So we are discussing shortening of dual antiplatelet therapy, which is of course good for those patients, but it would be much more safe if we before optimize stent with intravascular imaging guidance.
Very good point. Now I'm just going to sum up then, if we just pull up my last set of slides. interesting session. I showed you that case earlier on. You saw the two patients side by side. We just pulled that up. And various people voted for different ones where the imaging would be used. And I think we've got, the data's quite clear. We've got the techniques quite clear. And I think we've got some of the barriers unleveled now. We understand them a bit more. I mean, these cases are quite similar from different left mains, but they're both relatively complex. This one here, patient 1 ended up with a DK culotte and got a Megatron and a final pot. And then patient 2 received a DK crush technique and also had Megatron and got a pretty good result, I think, angiographically. Now, which one of those got imaging? Well, I suppose that's the big question. We should, from what I was saying before, I'd be doing it in both of them, but the case that got imaging here is number 2. And the reason is because they went into a clinical trial. So in my lab, I would do all these cases with imaging, but unless there's a clinical trial. And Optimal has just finished, it's just finished recruiting 800 patients. It's going to be fascinating to get this. Imaging wasn't mandated at the beginning, but it was mandated at the end. And I think you get all this great information and quantitative information to take away for yourself, for your patient, and for anyone else if the patient ever comes back. And I think we have now, I've turned the traffic light round, because if we see green at the top, we start thinking we should do it. So I think we should do it because we've got the evidence. I think we should do it because we need training, we need to recognize that. And I think if we can get over the cost and perhaps some of the logistics around integration around the cath lab and the time and the workflow, I think we can be in a better position to offer this to more patients. And actually, I know the studies suggest that it takes longer and there's more contrast, but the reality is, once you're image guided fully, it is quicker. And the studies have got a wide spectrum of participants, some centers doing very low volume and not very many cases, and of course they will take longer. But once you get slick at it, you get much better at it, and I think that's the key. And I think the next 10 years, if you're going to be using stents, we're going to be using more imaging. Of course, if we're using balloons, we may use less imaging, who knows. I want to thank my expert panel and thank you all for contributing. Thanks very much.